All right, welcome everyone. If you're on your interventional radiology or GI rotation, you already know that a call for a variceal bleed is one of the most serious you can get. So today we're going to do a deep dive into managing gastric varices with transvenous obliteration. These are some powerful techniques you absolutely need to have in your back pocket. Okay, let's get into it.
So first things first, let's just set the stage here. Esophageal varices get a ton of attention, but it's their gastric cousins that are often the real killers. They only show up in about 20% of patients with cirrhosis, but when they decide to bleed, it is almost always more severe, way harder to control, and it carries a much higher risk of death. And that's exactly why mastering the approach to these is so critical.
So here's our game plan. We're going to walk through the core challenge of gastric varices, talk about how we choose between treatments, and then get into why anatomy is absolutely everything for success. We'll look at the tools we use, the risks and benefits, and then wrap up with the key takeaways you'll want for your clinical practice.
So what is it that makes a gastric varix bleed so much more dangerous? Let's break down the specific factors that really make this a unique kind of clinical emergency.
The really interesting thing here is the pressure dynamic. See, unlike esophageal varices, these gastric ones can just rupture and cause a catastrophic bleed, even at lower portal pressures. So you combine that with a massive volume of blood loss, and the fact that they're notoriously difficult for our GI colleagues to control with an endoscope, well, you've got a recipe for a really bad outcome. And this, right here, is where we in interventional radiology get the call.
So, once the patient is stabilized, the big question is always, what's the definitive treatment? And we've got a few major paths to consider, each with its own kind of philosophy. The standard guidelines, like from the AASLD, show that the pathway starts with endoscopy, but like we just talked about, that often doesn't work. And that's what brings the patient to us for step 2, endovascular treatment. And this is where we hit a crucial fork in the road, where we have to decide between two major procedures, TIPS or transvenous obliteration. Now check this out. This table really lays out the fundamental difference between these two approaches. I mean, just look at the rows. A TIPS procedure is more invasive, and its whole goal is to decrease portal pressure, but that can make hepatic encephalopathy worse. Transvenous obliteration, on the other hand, does the complete opposite. It's less invasive, it actually increases portal pressure, and by redirecting blood back through the liver, it can actually improve encephalopathy and even short-term liver function. They are two totally different ways of thinking about the problem.
So if we decide to go the obliteration route, we can't just dive in blind. I mean it. Success is almost entirely dependent on understanding the patient's specific and often super complex vascular anatomy. It's all about the map.
And you don't have to take my word for it. This quote really says it all. You have to know the map before you start the journey. So that pre-procedural imaging, usually a CT angiogram, isn't just helpful, it's absolutely essential. It's how you plan your approach and, honestly, how you avoid failure.
We use two main systems to get our bearings. First is the Sarin classification, which just tells us where the varices are. For what we do, we're typically targeting the IgV1 and GOV2 types because they have the highest risk of bleeding. Then, and this is even more important for the procedure itself, the Kiyosue classification maps out the plumbing, the inflow and the outflow veins. And in the vast majority of cases, like 80 to 85%, the key outflow path we need to find is this big vessel called the gastrorenal shunt, or GRS.
Okay, so with that anatomical map in hand, let's take a look at the actual toolkit we use. This is a family of procedures that we call transvenous obliteration. The classic technique is BRTO, and the concept is really pretty elegant. You navigate a catheter backwards, that's the retrograde part, usually from the femoral or jugular vein, right into that gastrorenal shunt. Then you inflate a balloon to temporarily block the exit, and you inject a sclerosin. It's basically a chemical irritant that now is nowhere to go but backwards into the varices, which causes them to clot off and close for good.
So here are the basic steps. You get into the shunt, you inflate the balloon to get a good seal, you inject your sclerosant until the whole variceal complex is full, and then, and this is a really vital part of the whole thing, you have to leave that balloon inflated for several hours, sometimes up to a full day, to really let that sclerosant do its job before you can finally deflate and pull everything out.
Now, BRTO was the classic, but things have evolved into a whole family of modern techniques. PARTO is a huge step forward. Instead of a temporary balloon, we deploy a permanent vascular plug. This is way faster, and you avoid a long ICU stay with a balloon inflated. Then you've got CARTO, which uses coils and a gel foam slurry to do the same thing. It's great for really tricky anatomy.
And what if a patient doesn't have that classic GRS? Well, then we can use an antegrade approach, or ATO, by going directly into the portal vein.
These are really powerful techniques, for sure, but they are not without risk. So let's talk about the outcomes, both the good and the bad.
First, the rewards. I mean, look at these numbers. The technical success rates for these procedures are incredibly high, often getting close to 100%. When you do it right, based on the anatomy, you can successfully shut down the varices in pretty much every single case. But there are immediate risks. Anytime you thrombose a big vessel, there's a chance that clot can extend where you don't want it to, and the sclerosant itself can cause issues if it escapes. And this brings us to the single most feared complication of a classic BRTO, balloon rupture. If that balloon fails, all that sclerosant can shoot directly to the lungs, and that can be fatal. This is a huge reason why newer techniques like Parto and Carto have become so popular. Okay, now this brings us to the crucial long-term trade-off. Remember, we just blocked a major outflow shunt. So yes, that successfully treats the gastric varices, but what it does is increase the overall pressure in the entire portal system. And because of that, patients are at a high risk for developing new or worsening esophageal varices and ascites. This means that post-procedure endoscopy isn't just a good idea, it is absolutely mandatory.
But there is a silver lining to this increased pressure. By closing off that shunt, you're forcing more blood to flow through the liver, what we call hepatopetal flow, and this can actually help wash out toxins and improve hepatic encephalopathy. It's even been shown to improve liver function scores in the short term, which can be an amazing bridge for patients who are waiting for a transplant.
Okay, let's boil all of this down into the key points you need to remember when you're discussing these patients on rounds.
If you're going to remember just one slide from this whole thing, make it this one. This is the yin and yang of endovascular portal hypertension management. RTO techniques obliterate the varix but increase portal pressure. That worsens ascites and esophageal varices, but improves encephalopathy. TIPS does the exact opposite. It decompresses the system, improving ascites and varices, but making encephalopathy worse. Choosing the right one is all about the patient's specific clinical problem. So, to sum it all up, here are your pearls. Gastric varices are a high-stakes problem. Your success is going to live and die with the quality of your pre-procedural CT and your understanding of that anatomy. The main trade-off is fixing the gastric varix at the risk of making other portal hypertension problems worse. And clinically, here's the bottom line. You must make sure a patient has been screened for esophageal varices and had any risky ones treated before you send them for an RTO procedure.
And that brings us to what's next. For a long time, we really viewed these procedures as an either-or choice, but the thinking is starting to shift. We're now seeing them more as complementary tools that we can actually use together to manage these really complex patients.
Which leaves us with the final thought to chew on. If one procedure raises pressure and the other one lowers it, could the ideal approach actually be to combine them? Could we perform an obliteration to solve the immediate bleeding threat and then go in and place at TIPS to handle the rise in portal pressure that follows? That's really where the field is heading, and it's something to think about for the next complex case you see.